Good morning, everybody. Thank you for joining our Civic today. Today's presentation is called HIV/AIDS Awareness Month, 40 Years of Fighting Back. Today's presenter is Jonathan Berardi. He's a research nurse practitioner with the Cornell Clinical Trials Unit at Weill Cornell Medicine. He's a board-certified family nurse practitioner and holds additional certifications as a critical care registered nurse with subspecialty certification in cardiac medicine. In addition to his hospital-based roles, he is the Chief of Operations of the Mineola Volunteer Ambulance Corps on Long Island and holds certification as an EMT critical care. Jonathan is involved in clinical trials related to HIV, as well as COVID-19 vaccines and therapeutics. He is the study coordinator for the ACTIV-2 trial investigating outpatient treatment options for COVID-19, and he is the study coordinator of an HIV suppression trial. So the next voice you will be hearing is Jonathan Berardi. Thank you so much for joining us today.
Thanks for having me, and thanks for that introduction, Agnes. So as Agnes said, my name is Jonathan Berardi, and I'm going to be discussing a very brief history of HIV and AIDS here in the United States, spanning the past 40 years or 4 decades. I would like to make a very quick note now. A lot can happen in 40 years. So what we'll be discussing today is really more so a highlight reel, addressing the big momentous things that have happened in the fight against HIV and AIDS. But obviously not going to be able to do it full justice. 40 years is a bit tough to condense into just under an hour. So here, the outline that for the slides today, we'll discuss a brief history of HIV/AIDS in the United States and around the world. We'll also discuss the strategies to reduce the risk of HIV transmission. We'll review the screening and testing guidelines, as well as the treatment options, including pre and post-exposure prophylaxis, and some of the future goals of HIV research. So jumping right into a timeline of HIV/AIDS, the biggest question is, how did the HIV/AIDS pandemic start? And science has been struggling to answer this question for a number of years, but only recently have we actually identified that it came from a virus called the simian immunodeficiency virus. This was renamed after discovering its origins as the precursor to HIV/AIDS. It's a viral infection that's found in primates, so it's found in different types of monkeys, particularly in the Congo. And the first cross-species infection is believed to have occurred as early as the early 1920s. Because the number of cases were significantly lower than what we've kind of been used to or accustomed to starting in the 80s, we really didn't identify the virus for a number of years. Looking at preserved blood samples, we actually were able to identify that the earliest infection that we were aware of was all the way back in 1959, but cases and infections didn't become prevalent until the early 1980s. It was actually 1981 when there was a report submitted to the CDC. And in this report, it was on June 5th, there was a description of 5 individuals who had an uncommon type of pneumonia. This was a type of pneumonia called pneumocystis carinii, and really doesn't infect healthy individuals. So it was a bit unusual, it was a bit odd. And this report from June 5th would become the first official documented set of cases linked to AIDS. Over the next few weeks and months, more and more cases of this opportunistic infections, pneumocystis carinii, were coming into the CDC. And the CDC was starting to gather information on this severe immune deficiency, and predominantly among gay men. So not only was this pneumocystis carinii being observed, but also this unusual skin cancer called Kaposi sarcoma. And it was because of these 2 findings, so this pneumonia and this skin cancer, and this link to the gay community, terms like gay pneumonia and gay cancer were being used to describe this unknown phenomenon. The following year, 1982, the term GRID was being used in media, and GRID stood for gay-related immune deficiency. It was the descriptive term that was later replaced with the term AIDS, which stands for Acquired Immune Deficiency Syndrome. That term was first used on September 24th of 1982, and the term changed for two reasons. One, to reduce the stigma associated with gay individuals bearing this infection, and the other, because of some reports that were starting to come in of individuals who were not gay or bisexual also having this severe immune compromise. So in 1983 and 1984, we had some cases that were coming in, and as I mentioned, the term changed from GRID to AIDS because we were seeing these cases of individuals who were hemophiliacs being diagnosed with this immune compromised. There were also cases identified among heterosexual women. So again, removing that stigma away from just the gay community, although that link or association is still fairly prevalent today. These cases highlighted that this is not an isolated disease, that this is an infection that is spreading. The link to a bloodborne infection was prompted not only because of the type of contact individuals were reporting, but also because of hemophiliacs who were receiving blood transfusions all of a sudden becoming ill. And it was in 1983 and 1984 that we first identified that there was a retrovirus as the possible cause of AIDS. This team of French scientists in 83 and then a US team in 84 identified this retrovirus as being responsible for AIDS. The teams would be awarded with a Nobel Prize in 2008 for their work in the early years of the pandemic. When I say retrovirus, I do just want to clarify a little bit. The reason why this virus was so difficult to pinpoint and why it took several years from the start of the pandemic was this type of virus is able to work itself backwards into the host's DNA, hence retrovirus. As a result, it becomes very difficult to identify the initial virus that causes it because it incorporates itself so well into the host DNA. Over the next couple of years, we finally started to get some testing. So we have the first antibody test called an ELISA, which becomes commercially available. And that test was used to start screening the national blood supply. Again, there was that concern of individuals with hemophilia all of a sudden becoming severely immunocompromised, and that bloodborne infection theory that they were screening the national blood supply to eventually declare it free from the virus. In 1985, so 4 years after those first reported cases, we had the first International AIDS Conference, which was held. And later that year, President Ronald Reagan used the term AIDS publicly for the first time. And this was a major milestone because without the public recognition of this disease, there was no drive for change. So there was no federal funding. There was very low recognition or acknowledgement that there was a virus that was killing tens of thousands of people. In 1986, this HTLV3 virus that was first identified by that US team was renamed to the Human Immunodeficiency Virus, or HIV for short. So now, 6 years after those first set of cases, we had the first antiretroviral medication become approved by the FDA. This medication is AZT. This medication is still used today, actually. It still remains an effective treatment for HIV. But what's noticeable is the dosing is much less severe or much less intense than initial dosing. So it's about 5 times less than what it was initially. In 1987, you had to take pills every 4 hours to suppress the virus. But over time, as we learned more about HIV and about controlling the virus, we were able to scale that back to a degree. But imagine how difficult that must have been for people living with HIV at the time to have to take a pill every 4 hours. So it was quite a demanding and rigorous treatment option, but it was the only thing that was available. And it was the only thing that was available for quite a long time. In 1987, there was also a travel and immigration ban that was enacted for persons living with HIV and AIDS. And this was born out of fear of bringing the virus into the country or spreading the virus further into the country. We do see travel and immigration bans with COVID as well. And we know that they don't always work as effectively as we would hope. But again, we had this travel and immigration ban, which caused some disagreement. It wasn't well received by scientific community, but it was well received by the general public. So there was that disparity there. In 1987 as well, the first HIV vaccine entered clinical testing. And I'd like to point out that we, as of today, still do not have a vaccine against HIV. So we're still pursuing this some 35 years later. In 1987, we also had the first set of universal precautions that were introduced in healthcare settings. Prior to 1987, nurses and doctors and medical technicians, they would not wear gloves for most procedures. In fact, it was almost frowned upon because it looked as something being disrespectful, that I have to wear a glove to touch you, to care for you, kind of implying that you are not clean. So that it was widely frowned upon. But then with the advent of HIV, when that entered the scene, the CDC came up with a set of universal precautions to help mitigate the transmission of the virus. And at the end of 1987, there was a declaration issued by the American Medical Association that doctors are ethically obligated to care for persons with HIV and AIDS. And I find this statement to be the most powerful thus far, because for 6 years, you had a virus, a disease that was killing people. And there were medical providers, medical professionals who were refusing to render care or aid. That so much so that the American Medical Association had to issue this declaration. So imagine being a member of a marginalized community and being denied the care that we're all entitled to. So that was a very important moment in the fight. In the next few years, through further investigation, we identified the bloodborne route of transmission, and needle exchange programs were introduced, because using needles, whether it's for medical therapies or for intravenous drug use, needles were often not clean. They were used and reused, and that was promoting or contributing to the spread of HIV. So needle exchange programs were introduced for the first time in an effort to curb the spread of the virus. We had the HOPE Act signed into law by President Reagan, which helped us secure funding for HIV/AIDS research. And World AIDS Day was observed for the first time on December 1st, 1988. And it was in 1989 that we saw the number of reported HIV cases reach 100,000 reports. So this is just the first decade, and you can see that a lot had occurred over those 8 or 9 years. We were struggling to identify and manage and deal with an unfamiliar enemy, something that we had no idea what it was to begin with, let alone how to treat it. Kind of sounds familiar, especially with the COVID pandemic, but I'll discuss that later. So now we move into the next decade. And it was here in this period of 1990 to 1994 that we had even more advancements. So we had the American with Disabilities Act, which was enacted, and that provided federal protection against discrimination for persons living with HIV or AIDS. Of note, it only protected against discrimination based on an individual's status, whether they did or did not have the virus that causes AIDS. It did not prevent employers from discriminating against sexual orientation or lifestyle. And that was so closely linked and still is linked together that the protection really exists only for individuals who are dealing with the infection. We had the Ryan White Care Act of 1990 enacted, which provides funding for community-based care and treatment for persons living with HIV. Ryan White, for those who are unfamiliar or unaware of his case, Ryan White was a young person who was diagnosed with HIV after receiving a blood transfusion. He was a hemophiliac. He and his siblings were hemophiliacs, and they were actually denied entry. He was denied entry into his school because of his status, because he had HIV. So the Ryan White Care Act was enacted to promote HIV/AIDS awareness and education in the community. We have AZT, so that was the antiretroviral medication that had been used since 1987. Here in the 90s, it was actually approved for pediatric patients. Prior to this time, we didn't have a way to treat pediatric patients, despite the fact that there was a known transmission route of mother to baby. HIV is able to cross the placenta, so babies were being born with HIV, and there were no effective treatment options. I'm happy to report that we do have those options today. So individuals can be treated for HIV during pregnancy, and newborns can be treated as well. We also saw in the early 90s the advent of these rapid tests becoming available for medical providers. This increased screening capacity, so we were able to identify people who may have had HIV in a more timely manner. Prior to these rapid tests, it could take days or sometimes weeks to find answers. And in that time, individuals could have potentially been transmitting the virus to others without knowing it. So moving into the later 90s, so 1995 to 99, we have a new type of medication called a protease inhibitor, which was approved by the FDA. And this was the first time that a new class of HIV medication entered the scene. Prior to 1995, all of the medications that were available were all of the same class. With the introduction of this protease inhibitor, we were able to target and treat HIV using a more broad spectrum approach. By using two different types of medications, we were able to interfere with the virus at different levels or at different steps in the infection process. And in a very short period of time, within a year, the number of newly diagnosed cases of HIV/AIDS declined for the first time since the start of the pandemic. So almost 15 years later, we finally saw a decline in newly diagnosed cases. And that was as a result of not only increased education and awareness, but the ability to treat the infection more efficiently. We also saw the advent of viral load testing, and that was able to provide insight into how much virus a person may have had. And as a result, we were able to more, in a sense, customize individual medical care. Depending on an individual's response to the different medications they may have been placed on, we were able to start really tailoring the treatment to that person's disease state. We saw a third class of antiretroviral medication called the NNRTIs approved, and this added to that combination of the treatments available to lead to these combo treatments becoming available in one pill. For a period of time, it was multiple pills, multiple times a day. These combination treatments were able to reduce that burden for individuals. There was the emergence of this hit early, hit hard strategy. And what that approach was based on was identifying individuals who were infected with HIV and treating them as early in their process with as heavy duty medication as possible, or as high a dose as possible without side effects, to reduce the amount of virus in their system. We also saw national treatment guidelines emerge for the care and treatment of persons living with HIV. So now moving into the third decade of the HIV/AIDS pandemic, one thing that started to emerge and was concerning was this hit early, hit hard strategy, possibly contributing to viral resistance. And we'll talk about how viral resistance emerges in HIV a little bit later in this program, but there were some concerns about this resistance emerging. So there was a rethink on this hit early, hit hard. We had new screening tests developed that were able to use saliva samples rather than blood tests to screen for HIV. And this was available to medical providers, but in just a short period of time, about 10 years, this actually gained approval for over-the-counter use for individuals at home. What also happened in the 2000s, the late 2000s, 2008, the case of Timothy Ray Brown, who was dubbed the Berlin patient, was presented during an international conference, and he would later be considered functionally cured of HIV. So imagine, and again, as I said at the beginning, it's going to be quite difficult for me to condense 40 years of our history, our shared history, into just a few slides. But imagine how amazing this is, that we had 20, 25 years of persons living with HIV, struggling with the treatment options available, and ultimately succumbing to the disease. And now we have somebody who was considered functionally cured of HIV. Imagine how momentous that was. It was a reinvigorating point in HIV care and treatment, because it showed us for the first time that a cure may actually be possible. And by the end of the 2000s, we saw the 100th antiretroviral drug approved for use by the FDA. As of today, we use 30 different types of, or just over 30 different types of antiretroviral medications. So you can see that there were a lot of medications that were tried, and whether they worked or not, or had some significant side effects, over time, that list did dwindle down, but there was really a significant push to find as many treatment options as possible. Starting in 2010, the longstanding travel and immigration ban for persons living with HIV and AIDS was finally lifted. So this is about 23 years after it first being enacted. We finally lifted this travel ban, because we knew that banning people from traveling or immigrating to the United States was not an effective way to control the spread of the virus. And as a result of this travel ban being lifted, the International AIDS Conference, which had previously left the United States as a result of persons not being able to travel in, was finally held back here in the US. The national treatment guidelines were updated to recommend that all persons diagnosed with HIV should be treated with ART, or antiretroviral therapy, as soon as they're diagnosed. And this ties back to that hit early, hit hard strategy. Prior to this, individuals would be treated with various HIV medications, with the goal being undetectable, but it wasn't necessarily started immediately after diagnosis. So that hit early portion of the strategy wasn't present. And it was actually 2012 that the guidelines were updated to recommend that for all persons diagnosed with HIV. The first at-home HIV testing was approved by the FDA. This is a product known as Oraquick, which is available at any drugstore, CVS, Walgreens, Rite Aid, those types of places. And this was based on that same saliva sampling that became available in previous years. This provided expanded access for persons to test themselves at home, and it provided confidential results, which increased the overall rate of testing, because individuals, there was always the concern or the fear that if they were tested, they may be diagnosed with HIV, and then there may be some stigma attached. This allowed people to test themselves at home and not have to worry about that external stigma. What also happened here in the early 2010s was the approval of PrEP, which stands for Preexposure prophylaxis. And that's another major turning point in the fight against HIV and AIDS. PrEP allowed us to treat persons who were HIV negative, who were at higher risk of acquiring HIV, with the same medications used to treat persons living with HIV. Because of this pre-exposure prophylaxis, or this PrEP, we were able to prevent transmission of the virus. In the later portion of the 2010s, we had another major step in that blood donor ban was revised. So previously individuals living with HIV or who are at higher risk of acquiring HIV were banned from donating blood for life. This has since been revised, and it includes particularly men who have sex with men based in certain situations, knowing that men who have sex with men are at higher risk of acquiring HIV. This ban was revised, and the current guideline is that provided an individual has not had sexual contact for over a year, they are eligible to donate blood. This caused a significant amount of controversy because there was still the fear of this gay-related illness, right? Going back to that GRID term, this gay-related illness that men who have sex with men are more likely than others to have or to contract HIV. And that's simply not true. There's actually statistics that show the rate of HIV transmission among partners is equal whether it's the heterosexual or homosexual community. So this notion of tying a disease to a particular group was finally starting to lift. It was finally starting to ease. We saw a wide body of evidence coming out in 2016 and 2017 that showed persons living with HIV who have undetectable viral loads are subsequently unable to transmit HIV to uninfected individuals. And this became what is known as the U=U campaign. So if you are undetectable, you are untransmissible. And that has been a major point for all individuals being treated for HIV, is to get their viral load to an undetectable level to reduce that risk of transmission. PrEP becomes officially recommended as preventative therapy for all persons at high risk of HIV infection. And we saw another report of a person called the London patient. This was a person similar to the Berlin patient. And speaking of both of them, they were individuals who received bone marrow transplants, but they received bone marrow transplants from very specific individuals who had a very specific mutation that interfered with the ability of HIV to infect cells. And after receiving these bone marrow transplants, they were able to come off their antiretroviral therapy and remain off. And again, they are considered to be functionally cured of HIV. So now this brings us to 2020. And as I'm sure everybody remembers, 2020, we saw COVID. And there's a reason I'm putting this slide here and dedicating this entire slide to COVID. One of the most important things and one of the most influential things in the fight against COVID is our 4 decades of experience with the HIV/AIDS pandemic. Because of the research, the testing strategies, the treatment options that were all studied and developed in response to HIV/AIDS, we were able to very quickly respond to the COVID pandemic. We had an entire network of research sites. It's called the ACTG, the AIDS Clinical Trials Group. And this whole network of sites that had been studying HIV and HIV-related illnesses for so many years was able to quickly shift to studying a new virus, and that was the SARS-CoV-2 virus. As a result, we've been able to curb the COVID-19 pandemic significantly in just 2 short years compared to the 4 decades in fighting against HIV. So that's the brief history of HIV and AIDS. Again, I'm not able to do it justice. 40 years is a lot of time, and there were so many significant developments. There were so many tremendous losses that hopefully those slides are just a brief insight into what we've experienced over the past 40 years. But now I'd like to talk about reducing the risk of HIV transmission, kind of leading into today. So when we look at the risk factors for HIV transmission, we're really looking at any type of contact where blood or bodily fluids may be exchanged. So individuals who engage in unprotected sex, individuals who have multiple sexual partners, particularly if those sexual partners have an unknown HIV diagnosis or unknown HIV status. If an individual is currently infected with another sexually transmitted infection, that also increases the risk for HIV transmission. Individuals who use injected medications or drugs, particularly intravenous drug users, and occupational exposures such as needle stick injuries. These are high risk factors for HIV transmission. So all of the testing strategies and the treatment strategies that we have are looking to interact with these risk factors. They're trying to mitigate these risk factors as much as possible. So that's where safer sex practices are encouraged. There's free access to condoms in most public places here in New York City. Condom use in general is promoted for the reduction of HIV transmission. And knowing your status is really the most important factor to it. So when we look at the risk reduction, there are three areas or domains that we would really tend to focus on. The first would be testing. Again, knowing your status, knowing if you do or do not have HIV, because that's the first step in preventing the spread of the virus or the spread of the infection. The second would be treatment, and we can reduce risk by treating both prophylactically, either as pre or post-exposure prophylaxis, or as treatment with daily medication to attain that undetectable viral load. And the third domain would be prevention, so preventing the spread of the virus. So the first domain that I'm going to talk about is testing. And I'm going to break this down into screening and testing. So when we look at these two definitions, screening is a way to identify potential disease in otherwise healthy persons. It's estimated that anywhere from 10 to 15% of individuals living with HIV are unaware of their status. And that's because while we oftentimes associate acute HIV infection with generalized symptoms, flu-like illness or flu-like symptoms, not everybody experiences those symptoms. And as a result, they would be unaware of their status. They would not go out and seek testing, and they may transmit the virus unknowingly to other individuals. So screening looks to identify that potential disease in healthy persons. There's no index of suspicion, there's no symptoms, but we want to screen everyone because, again, of that 10 to 15% who are unaware of their status or unaware of their HIV status. Screening is performed as part of routine care, and it's considered a preventative approach. Screening itself is also not considered to be diagnostic. So with screening, and this is where we have our sensitivity and specificity types of trade-off, with screening, if the screening test comes back negative, then it is a conclusive negative. If the screening test comes back positive, that doesn't always mean that you have the infection, but it means that follow-up testing is required. And that's where we move into this testing column. Testing is indicated when there's an increased risk or increased index of suspicion for disease. So if a screening test comes back positive, we would proceed into testing. If a person comes in, they report a high-risk behavior, such as unprotected sex or intravenous drug use, and they're now experiencing mild flu-like symptoms, that would increase the index of suspicion. So a very careful history and a very open relationship with the provider will help to pull out all of that information. And that may make the difference between screening and testing. Testing is performed as needed, particularly when risk factors are present. And testing is considered diagnostic. So the results provide confirmation, of the presence or absence of a disease. So when we first look at screening for HIV, The current guidelines recommend that all persons between the ages of 13 to 64 should be screened at least once as part of their routine primary care. And here, as of 2019, this is from the CDC, approximately 13% of persons living with HIV are unaware of their diagnosis. And this is why it's so important to screen everyone. Now remember, this recommendation or this guideline says that screening should be conducted at least once. It doesn't mean that screening can't be performed more than once, and it certainly is performed more often, depending again on an individual level and individual risk factors present. But at least once, everybody should be screened. And this is to help identify those who may be unaware of their diagnosis. Another way that we screen for HIV is actually when blood donors go to a donation center. They're screened at the time of donation using a set of screening questions. So those questions, and for anybody who's ever donated blood, it's a fairly large, lengthy piece of paper. They ask you a whole bunch of questions. And in there are screening questions that may indicate an increased risk for HIV. So those screening questions help the donor center staff identify individuals who may be at a higher risk, and they may defer donation until testing or other information becomes available. Not only are the blood donors screened, but all of the blood samples are also tested for the presence or absence of HIV, as well as other infectious and communicable diseases. Pregnant women should also be screened for HIV. Screening should occur at least once at the very beginning of pregnancy, so as early into pregnancy and prenatal care as possible. And this is to identify, again, any individuals who may be living with HIV who are unaware of their status. There are medications that are safe and effective to use during pregnancy that can help reduce the risk of what we call perinatal or mother-to-child transmission of HIV. Not only is it recommended that all pregnant women, and this is an opt-out approach, so individuals can decline the test. Not only is it recommended early in pregnancy, but it's also recommended to have a conversation with your provider prior to becoming pregnant. Knowing your status before becoming pregnant can also allow that time to start ART or to start medication to further reduce that risk of HIV transmission. Now, when we talk about testing for HIV, this is where, again, testing, just to kind of bring back that definition, testing is used when there's an increased index of suspicion, where we want a more sensitive ability or more specific ability to look at, is somebody truly infected or not? All persons with self-reported high risk, so going back to a few slides before, that list of 5 or 6 categories, all persons with the self-reported high risk for acquiring HIV should be tested every 3 to 6 months. It certainly could be performed more frequently than that, but it's very important to be aware of your HIV status, especially if you're engaging in higher risk activities. Testing should occur after a high risk exposure, and exposure could be what we consider occupational or non-occupational. So for example, an occupational exposure would be in the healthcare setting, an accidental needle stick. Non-occupational may be related to sexual intercourse or intravenous drug use. But if there's high risk exposure present, testing should occur as soon after that exposure. Individuals are also tested for HIV before starting medications to prevent HIV acquisition. And that's what we would call that PrEP or PEP. And that's that pre and post exposure prophylaxis. We will test for the presence or absence of HIV prior to starting those therapies. The recommendations say that we can initiate the therapy while waiting for the results of that test, although some providers would like to defer just until they have a confirmation on whether or not someone has HIV. And that's because that may change the direction of the treatment. We'll talk about PEP and PrEP in a few slides, but there would be a reason why we would not want to use PrEP and PEP for individuals with HIV. So in terms of treating HIV, we use a group of medications called antiretroviral therapy. There are several different types of ART. So we're well aware of the overall pathway that the virus takes when it invades a cell. And knowing those different parts of the pathway and the different steps, we're able to interfere at very specific points. So for example, we have these reverse transcriptase inhibitors. So we prevent the virus from inserting itself into the host DNA. We have fusion inhibitors, which prevent the virus from being able to stick to the host cells. By identifying those different parts of the pathway and having medications that interfere at those different parts, we're able to block the virus from invading cells, and we can take multiple approaches at the same time to increase or enhance the effectiveness of this ART. Now, this next slide, this is quite a busy slide, but this is a great image that was published in the article referenced. And it shows how over time, we really built up the amount of available ART, and the different colors represent the different types of ART that are produced. So there are the NRTIs, the protease inhibitors, the integrase inhibitors. So you can see how over time there were really big pushes over different portions and decades to bring us to where we are today. And what's most important that I want to point out is some of these medications, as you can see, they have a little registered or the trademark, and they're in black text. And those are what we would consider to be the combination pills or combination therapies. So why do we have combination therapies? Well, viruses like COVID and HIV, viruses make copies very quickly. Their goal is to make as many copies as quickly as possible and infect as many cells as possible. And because of this very fast process, there are errors that occur. These errors are also called mutations. Sounding familiar because with COVID, we have all the different variants, and it's a similar reason why, because we're making a lot of copies very quickly. Some of the errors are non-functional, meaning that they actually don't allow the virus to do its job any more efficiently or any better. But some of these errors lead to resistance against different classes of ART. Because of that resistance, we want to use, again, those multiple medications from multiple different classes. And this is similar to antibiotics, where we want to use broad spectrum antibiotics when we don't know what the infection is, and then we kind of tailor and hone in on what could be the possible cause and customize the therapy to that. Similar here, except with a virus, we're not necessarily worrying about the bacterial resistance, we're worrying about the ability of the virus to make mutations. Once those mutations are established, they can be transmitted to other individuals. So we want to prevent them from emerging in the first place. By using multiple different classes, we're able to mitigate that risk, because if one mutation emerges that is resistant to one type of ART, but is susceptible to another ART, by having a combination therapy, we're able to reduce the risk of that mutation spreading. Not only does this help us to manage or mitigate the possible resistance that could emerge, but it also helps to simplify daily requirements. And that's huge. When you think about taking medication, the easier the dosing instructions, the more likely it is that individuals will remain compliant with that therapy. So if you have to take multiple pills multiple times a day, there's a chance that either A, a mistake will happen and you might miss a dose of one or another, or B, you may just become tired and frustrated from having to take so many pills. So by combining these pills into one tablet and having that tablet being dosed once a day, it significantly helps to improve compliance and overall improvement in the goal of therapy. This is an image from NIAID, which is a great depiction of how far we've come, especially with this combination therapy. Again, you see here multiple pills, multiple times a day, depending on the different regimens, up to 20 pills a day, taken at all different hours. Some are every 4 hours, some are every 6 hours, compared to today, where you take one pill once a day. And while one pill once a day is fantastic, over the past 40 years, we've gone one step further, and we've actually started using injectable medications. So these injectable medications are different types of ART or antiretroviral therapy that have been formulated as a long-acting injectable medication. The injections slowly release the medication over the time to have that desired effect, but it reduces the need for daily pills. And we have this medication here, Cabenuva, which is a combination of cabotegravir and rilpivirine. And this was approved by the FDA January of this year. And this dosing is actually monthly injections. So looking back on this slide, we have 20 pills once a day, coming down to one pill once a day. And now we're here, 2021, and we have these 2 injections that are administered once a month. So we've come a very, very long way. Now, again, these medications may not be appropriate for everybody. So if there is any consideration for this, speak to your provider. But this is a significant improvement and a huge step forward in the fight against HIV and AIDS. So now we've covered testing, we've covered treatment. The last thing we're going to cover is prevention. So preventing the transmission of HIV, arguably the most crucial part of fighting back. If we can prevent the virus from spreading, then we are doing much more than if we're trying to treat or manage a new infection or a current infection. So if we can prevent the transmission, then we are going to make huge strides. And those are major goals, not only here in the US, but around the world, is to reduce transmission. Preventing transmission of HIV can be in the form of safer sex practices. So using condoms, knowing your status and knowing the status of your partner. And it should be an honest and frank discussion that you have, just asking are you aware of your HIV status? Have you been tested for HIV? Individuals, there's still that stigma of a person living with HIV may not be appropriate as a partner, but the evidence is overwhelming to show that what we call serodiscordant couples, or couples where one partner is HIV positive and the other is HIV negative, the risk of transmission is virtually zero when the infected partner is taking their daily ART and the uninfected partner is taking PrEP, or that pre-exposure prophylaxis. In addition to safer sex practices, syringe exchange programs can also help to prevent the transmission of HIV. We have the medications that we discussed, that pre-exposure and post-exposure prophylaxis. We'll talk about in the next few slides. And the use of universal precautions in healthcare. I cannot overemphasize this statement enough. The most important way to prevent the transmission of HIV is to know your status. As the old adage goes, knowledge is power. And in the fight against HIV and AIDS, it could not be more true. Knowing your status is the best way to prevent the spread of the virus. Now, I spoke about the pre and post-exposure prophylaxis. So in the last few slides, I'm going to wrap up with discussing these options as well. So pre-exposure prophylaxis helps to prevent acquisition of HIV if you are exposed. This is indicated for individuals who are at higher risk of HIV infection. It's basically a modified version of ART. It's a 2-drug combination therapy taken once a day. It does need to be taken daily to be most effective. And it's, again, indicated for individuals at higher risk. You may have seen commercials. There are currently 2 medications that are FDA approved. There's Descovy and Truvada. And we use these 2 medications to prevent the spread of HIV by preparing the system, right? So if you're taking these medications on a daily basis and you have these antiretroviral medications circulating, then if you're exposed to the virus, these medications would be able to begin working immediately to reduce the likelihood of the virus infecting a host cell and taking root in the system. Again, has to be taken daily to be effective. There is some consideration that's being given to some of the longer acting antiretrovirals, or evaluating if on-demand dosing options may be valid. But right now, the current guidelines, the current recommendations would be to take it once a day for the most efficacy. Now, we use this 2-drug regimen because we want to mitigate the potential side effects. So we want to reduce side effects that are experienced by the persons taking it. Again, the more side effects that you have with the medication, the less likely it is that you would want to continue taking that medicine. So we use 2 drugs to achieve this goal. It does not prevent the spread of HIV 100%, but it is significantly reduced. So it is an excellent option for individuals at higher risk. And this is why we want to, going back to testing, we want to test before starting these medications, because the current medications used for the treatment of HIV are typically 3-dose or 3-drug regimens versus the 2-drug. So this is kind of preparing for possible exposure. But what happens if you are exposed? So if you're exposed, whether it's an occupational or a non-occupational exposure, if you're exposed to a person's blood or bodily fluids, then you would want to speak to your provider about post-exposure prophylaxis. In order for this to be most effective, it needs to be started within 72 hours of exposure. So make the phone call right away. It's a 3-drug regimen, which differs from PrEP, which is as a 2-drug regimen, because there's the assumption that if you're exposed to someone whose status is unknown, or if they're suspected to be HIV positive, the assumption is that the virus may already be present in the system. So by using the 3-drug regimen, we're able to target and attack what small amount of the virus may be circulating to prevent that from getting any larger or becoming a larger infection. PEP is taken for 28 days, and that's been shown to be more effective than taking it for 3 days or 10 days. And that's because, again, there's the assumption that the virus may already be present. And if the virus is present, it may have made more copies. So by taking the therapy for 28 days, that helps to ensure if there are copies circulating, we're reducing the possibility of those, providing more fuel for the fire in a sense. And finally, looking at future goals of HIV research. So not only with all of the advancements that we've had and the different types of pre and post-exposure prophylaxis, the medications, the testing, the treatment. One of the major things that's been happening is the antiretroviral therapies and the care and treatment options that we have today are so effective at reducing the virus that what was once considered a death sentence back 20, 30 years ago is now considered something that is completely benign in terms of long-term health and care. And I say benign in the sense that life expectancy is virtually unchanged for persons with well-controlled or treated HIV. But we have now the other side of the coin, with persons living longer and living more fulfilling lives. We're now starting to see the long-term effects of HIV infection and the long-term effects of the antiretroviral therapy. So HIV infection and treatment can contribute to increased risk for cardiovascular disease, neurocognitive disorders. So these are all areas of investigation that are currently underway to identify and possibly mitigate the emergence of those disorders later in life. We're still seeking to find that vaccine to prevent HIV transmission. It's been an ongoing pursuit since 1987. And often we hear, well, we came up with a vaccine for COVID in just a year. Why haven't we been able to do the same for HIV? Well, HIV, because of the type of virus that it is, it mutates and changes very quickly, making it much more difficult to target. So that's what has led to such a challenge in finding this HIV vaccine. but we're still pursuing it. We're still trying to get there because, again, prevention is the most important part in managing the HIV/AIDS epidemic. We are investigating longer acting treatments to maintain viral suppression. Like I said, we have that once a month, that once monthly dosing that's available, but what if we can make that last even longer? What if it could be treatment once every 2 months, once every 6 months, once a year? That would significantly improve the quality of life as well as reduce the burden for persons living with HIV. And we're also exploring in the realm of research what we call functional and complete or sterilizing cures. And yes, I said cures. We are still trying to cure HIV. 40 years later, we still have not found the magic bullet, so to say. But there's a significant body of research that is working towards that. When I say a functional cure, what I mean is there's no evidence of infection, so an undetectable viral load, but there may be some trace amounts of HIV that could potentially reactivate over the course of a person's life. However, individuals that are functionally cured would not need to take their ART, whether it's daily or monthly. A complete cure would be completely eliminating the virus from the body. And that is the ultimate goal of HIV research. It's a very interesting field. HIV researchers are, I guess, one of the few groups of professionals who are actively seeking to find themselves out of a job. We see this with cancer therapies. We see this with HIV research. We're trying to find a way to stop the disease that we're treating. And that would be an incredible and momentous day in history and a fantastic way to celebrate the 40 years of history that we already have. But that's where we're looking forward to, and that's where we're heading. And with that, all set.
Thank you so much, Jonathan. If anybody has any questions, feel free to write in the chat as well. Or you could just unmute yourselves. I'm going to start a poll while everybody thinks of some questions, or if they'd like to, or if they're typing them in the chat.
I have a question. This is Lula May. Can you hear me?
Yep.
Okay. Has there been a mutation in the virus in any way? Has it mutated over time? Has it changed a lot?
That's a great question. So it has mutated over time. In fact, looking back to the origins of HIV and that transmission of the simian or SIV to humans, there are actually different groupings of HIV. There's M, N, O. There's also HIV-1 and HIV-2. So there are these different mutations that cause like a base grouping. And that helps to target and direct some of the therapies. Here in the United States, HIV-1 is the most prevalent form. Whereas if you look at, for example, South Africa, HIV-2 would be the more prevalent or predominant form. In terms of the mutations that have developed over time, that's really been in response to the different therapies that have been enacted or put into use. And of course, similar to antibiotic resistance, the longer we use something, the more likely it is that resistance may emerge or develop. We haven't seen significant enough resistance where all treatments are rendered ineffective, but it certainly does complicate the treatment options because you may have to be on more, a broader range of medication to control the infection.
That's great. Another concern of mine is I know life expectancy has increased, but it has increased tremendously. Now there are people up into their 70s and 80s that are on meds for HIV.
Yes.
And the other question, the symptomatology, has it changed, or does the presenting signs change with the type?
So another great question. So the presenting signs are, they don't often change with the type of HIV somebody may be exposed to, but the main challenge or the large challenge is that the symptoms oftentimes are very general. They're not very specific. For some individuals, they could be as mild as, just your run-of-the-mill kind of head cold or something. For others, it may feel like a full-blown flu, but they're limited in duration, and it may be very easy for you to ascribe that, okay, maybe I had like a bad virus, and then you recover and you get better, and it may not prompt you to seek treatment. So that's where the symptoms overall, and again, major caveat to that is if an individual even experiences symptoms. Some persons don't necessarily experience those flu-like symptoms after contracting the virus. So if a person has a potential high-risk exposure and they shortly after begin to experience flu-like illness, definitely seek care with your primary provider for HIV screening or testing.
So it seems that what I'm hearing you say is that because of the mildness in its symptomatology, it's really an ongoing, really big problem.
Yes, it really is, because it's not, it's not like COVID, for example, where, and even with COVID, some people have very mild form of COVID that they don't realize that it was COVID until long after the fact. It isn't really until you have those more abrupt symptoms, like losing your sense of smell or taste, that you go, oh, wait a minute, this could really be COVID. We don't really have that with HIV. We don't have one specific symptom that would say, yes, this is definitely HIV. It's really like any other virus that would invade a person. It's that the general types of body aches, the muscle aches, stiff joints, maybe a fever, and goes away in a couple of days. So it becomes very challenging to treat and identify, which is again why, the current guidelines and recommendations is that at least for persons between the ages of 13 and 64 to be screened at least once in your lifetime for HIV infection.
Wow, just one? It's just once?
Those are
once?
Yeah, those are the
guidelines.
But I have heard of, and I have seen practitioners who engage in screening more frequently than that. Again, the best way to prevent the spread of the virus is to know your status. So even if your primary care provider doesn't want to screen more than once, that's what the guidelines say, but it certainly is a conversation you can have with them to be screened more often or more frequently.
That is so true. I think the Department of Health is still doing screenings for free, aren't they?
Yes.
And you don't need an appointment. You could just walk in, from what I understand.
Yeah,
Okay.
you may have a little bit of a wait time, but many places accept walk-in for screening, because again, the goal is to identify as many people as possible so that we can connect them to care and treatment as early in their disease state as possible. And again, knowing your status is the most important way to prevent transmission.
Wow. You know something, I honestly, in my mind, I thought the numbers were decreasing overall. Are they, or have they maintained a steady incline, or has it been a steady decline? Steady, I mean,
Great question. So yeah, we have
progression. Has it been a slow progression up or a slow progression decline?
So we've also seen a decline in both the number of new cases as well as the number of persons living with HIV. One of the concerning areas is there does seem to be kind of a plateau effect of persons who have not been connected to HIV care. So that's something that we're certainly working on, especially with respect to the disparity that exists at who belong to connect HIV care and treatment as soon as we as healthcare providers can certainly, we want to make sure that everyone is to affordable or free HIV care when they're diagnosed, so that we can again prevent the transmission of the virus. But the other numbers, the number declined over the past.
Overall, that's good. Well, thank you so much for such informative information. Thank you.
It's a funny thing with COVID fatigue. People are silly about in-person AA meetings and things, or other such things, or Christmas. I mean, the trifecta of giving the coronavirus is going to play, but a lot of people are staying home. They're not partying, they're not hanging. And I know the pregnancy rates have been going down. The unwanted pregnancy rates. My sad hunch is when we finally get on top of COVID, suddenly the HIV stats are going to change.
Yes, and that is something that we're paying close attention to. When COVID first hit, especially early, March, April 2020, and everybody just so quickly shifted into this lockdown. So much, even in healthcare, so much became remote or telemedicine visits, that individuals who may have been experiencing those mild symptoms, especially those mild flu-like symptoms, they'd be sent for COVID testing, because being here in New York, just like with HIV, New York was an epicenter for COVID. So we were hit so hard with that everybody was thinking, if you have any upper respiratory type of symptoms, it's most likely COVID. So you'd be sent for a COVID test, it would come back negative, and they'd say, okay, maybe it was another virus, without thinking maybe that other virus was HIV.
It's a pity that they haven't doubled up, where you go to these little pop-up tents up and down Broadway to get coronavirus testing. What the hell? Grab them by the ears and test them for a whole bunch of things. Because the hardest thing is to get them to walk into the tent.
Yeah. And once they're there, they're at least interested enough in being tested for one thing, then you might be able to say, hey, with help of your cheek, we can also test you for your HIV status. And while you're here waiting for the COVID test, we could do both, trying to promote that public awareness and that public knowledge. I think that, again, the challenge has been that COVID was a new pandemic that we really, similar to HIV, we had no idea what we were looking at. We had very little information to go on. So I think that's where the main focus.
Might there be some initiatives to reach back to the public health departments, at least in New York State or in New York City, certainly, and say, hey, you're missing an important opportunity to get on top of more than one disease at the same time? Is it a funding issue or an understanding issue, educational issue? They don't get it.
That's a great question, and I'm not sure, but I'm certainly going to be doing a little bit of digging on my end now, just to see if there were any discussions, and maybe if it was just the logistics of getting it employed, or if there was some other barrier, or maybe if it wasn't even considered at all. But yeah, I'm certainly going to look into that a little bit more.
I mean, you couldn't do this on the street pop-up tents because it's now winter, it's getting cold, but they also do them in shopping malls and things. It'd be great if you did if you offered screening for high blood pressure, diabetes. I mean, they're there.
Yep.
It's hard to get them. They're at least minimally interested in getting healthy. Yeah.
Something, Larry, I think it's a good idea, but now you have to consider the temperament of our communities. They don't want to be vaccinated, they don't want a COVID vaccine. Now you're going to be asking them to look at more of their information. Very challenging.
Oh,
If you figure that out, you're
oh, yeah.
going to be a winner.
Oh, yeah, I've got a great joke for you. This is one of the late night hosts is saying, one way to fight disinformation is with more disinformation. If only we start a rumor that the COVID vaccines help to lose 20 pounds, they'd be selling out in an hour. If you lie and say, I took the vaccine and I fit into my jeans by the time I got home, wow, they go like hotcakes. But, speaking about disinformation, it's interesting. I have not heard any kind of intentional, energetic disinformation on HIV testing or any therapies for HIV. The crazies will happily walk off the edge of the cliff on COVID, don't seem to take the same energy on HIV.
Well,
Thank
you
God.
know, yeah, well, that's true. But I think, again, a lot depends on the community, because I go to a lot of meetings at the Department of Health, and they're still, it be prior to COVID, I have to say that. There was a great need. There was a vacuum for information about HIV, as a matter of fact, and I think there still is. That's why I'm so grateful that Jonathan was able to do this talk today. And I just would like for more people to hear it, because I think it's so important.
Well, you recorded it, and frankly, it would save his voice. It was such a nice presentation. It was both comprehensive and
Yes.
approachable. You
Yes.
don't need to have a medical degree to follow it, but you pulled a
That's
huge
true.
amount of information together. It'd be a really great piece to put out on the web for public
Yes.
information.
Well, that's what we're going to do. We just have to be we'll talk. Cause I gotta get it out. And
Yeah, done
really,
good, Jonathan. I mean, really, it was a nice, crisp.
Thank you.
It's one of those, I think you've done this once or twice. You've obviously facile practice, really great public speaker. Hard to get a lot of this stuff across. Done good.
Thank you. I appreciate that.
so true.
The only other thing in the same context, if you did a website, start with the audio, run it through one of these free speech to text tools so you can get a transcript, and then add footnotes to things like, what was the term you used? Hold on. Serodiscordant couples. It's not a term you hear very often. Reverse transcriptase inhibitors, and then have a link where people could look up more information.
Something, Larry, that's a great idea. I'm writing it down.
I love you, Lula May. Thank you, dear. You get two for the price of one. Just feed it right there. Got the audio. And by the way, you can, when you are recording under Zoom, you have the option of getting just the audio as opposed to audio and video. But given the audio, to go from speech to text is both free and very easy. They're great tools out there, and they're remarkably high quality on the speech to text. And there you are.
Thank you so much.
My pleasure.
Okay.
Lula May's used to me. I'm sorry.
Agnes, I'll turn it back over to you.
Okay. Thank you so much for presenting today, Jonathan. That was amazing information that you shared today. For those that want the recording, we'll have it uploaded by YouTube by tomorrow, the latest, and I'll share it to everybody's emails. And if you have any further questions, please feel free to comment on our YouTube channel or send us an email.
Thank you.
Okay.
Thank you.
Have a good day, everybody.
Have a
My
great
pleasure.
day.
Take care.
blessed
May keep
one.
in touch
I shall. Bye-bye.
and have a good new year, everybody.